Today's lecture is about casts, splints, and braces, some of the most common immobilization devices used in musculoskeletal care. We'll cover their types, uses, complications, nursing management, and what patients need to know for home and transitional care. Casts. The basics. A cast is a rigid external device molded to the shape of the body. It immobilizes a reduced fracture, supports healing, prevents or corrects deformity, and stabilizes weak joints. Casts allow mobility while protecting the injured body part. Common types: arm casts, short or long, sometimes thumb spica; leg casts, short or long, sometimes reinforced for walking; body casts, encircle trunk; spica casts immobilize hip, pelvis, or shoulder. Specialized casts, walking boots or air casts for weight-bearing protection. Casts must be properly fitted. If applied incorrectly, they may hinder healing or cause complications. Materials: fiberglass versus plaster. Fiberglass, lightweight, durable, water-resistant, radiolucent, X-rays pass through. They set in 30 minutes and may use waterproof liners. Patients can shower or swim, but casts must be carefully dried to prevent skin breakdown. Plaster, less expensive and easier to mold, but heavy, not water-resistant, and take 24 to 72 hours to dry. Handle with palms only to avoid dents and let them dry uncovered. Pedaling or moleskin may be needed to prevent skin irritation. Splints and braces. Splints are non-circumferential, easy to apply, allow for swelling, and are often used initially for simple fractures or soft tissue injuries. They are faster to apply but less supportive than casts. Braces are longer-term supports, often custom-fitted. They control movement, prevent further injury, and improve comfort. Examples include knee immobilizers, ankle stirrups, and wrist splints. Nursing management before and after application. Before applying a cast, splint, or brace, the nurse assesses general health, skin condition, and neurovascular status. Wounds must be cleaned and dressed before immobilization. Patient and family education is crucial, explaining the purpose of the device and what sensations to expect, such as heat from plaster or fiberglass hardening. After application, the nurse's top priority is neurovascular checks. Assess circulation, motion, and sensation every hour for the first 24 hours, then every 1 to 4 hours. The 5 Ps, pain, pallor, pulselessness, paresthesia, and paralysis, are red flags for complications. Pain is carefully evaluated. Normal pain should respond to elevation, ice, and medication. Unrelieved pain, especially burning pain or pain with passive movement, may signal compartment syndrome or pressure injury. Never ignore pain under a cast. Complications of casts, splints, and braces. Infection. Warm, moist environments can harbor bacteria. Signs include odor, drainage, or fever. Foul-smelling casts should be removed and inspected. Acute compartment syndrome. Casts can trap swelling and restrict circulation. If suspected, casts may be cut, univalved or bivalved. Definitive treatment is fasciotomy. Pressure injuries. Patients may complain of a hot spot. Drainage or odor may occur. Cast windows may be cut for inspection, but soft tissues must be protected from bulging edema. Disuse syndrome. Prolonged immobilization causes muscle atrophy and weakness. Prevention includes isometric and setting exercises performed hourly. Isometric and muscle setting exercises. Quadriceps setting. Supine, leg extended. Push knee down, contract thigh for 5 to 10 seconds, then relax. Repeat 10 times every hour. Gluteal setting. Supine, legs extended. Contract buttocks for 5 to 10 seconds, then relax. Repeat 10 times every hour. These simple exercises help maintain strength and circulation even while immobilized. Transitional and home care. When casts are removed, patients often feel anxious. The saw vibrates but does not cut skin. The limb will be weak, stiff, and scaly from dry skin. Patients should avoid scratching and instead use warm soaks and emollients. Activities should resume gradually, with continued elevation to control swelling. Upper extremity casts. Patients need strategies for one-handed ADLs. The immobilized arm should be elevated above heart level and supported in a sling when walking. Nurses must monitor for circulation issues and prevent complications like Volkmann ischemic contracture. Lower extremity casts. The leg is elevated to heart level, cold packs applied as ordered, and toe-ankle exercises encouraged. Nurses assess for peroneal nerve injury, which can lead to foot drop. Safe transfers and ambulation training with crutches or walkers are essential. Body and spica casts. These require special care. Cast syndrome, or superior mesenteric artery syndrome, can occur when the duodenum is compressed. Symptoms include abdominal distension, nausea, bilious vomiting, and anxiety reactions. Nurses must monitor bowel sounds, provide reassurance, and ensure patients and caregivers receive education on hygiene, positioning, and complication signs. Conclusion: casts, splints, and braces are vital tools for healing musculoskeletal injuries, but they come with risks. Nurses play a central role in early assessment, preventing complications, teaching exercises, and supporting patients and families at home. Our vigilance and education directly impact recovery and quality of life.